Good afternoon. I think we can start our afternoon session. So it's now 1:30, and I'm very happy to welcome all our colleagues to this session. I'm a chair, and my name is Julia Kravchenko. I'm from the Department of Surgery, Duke University School of Medicine. We will have 7 presentations at this session, 30-minute each presentation. And panelists can raise their hands using the button at the bottom of the screen. And the audience can pose their questions at Q&A. And questions will be answered to the and at the end of each presentation, if we will have enough time. If no, we will move all unanswered questions to the panel, to the roundtable section at day 2. And now I think we can start, and I would like to introduce our first speaker. Our first speaker is Dr. Frank Bandiera from the National Institute of Aging, Division of Behavioral and Social Research. And Frank Bandiera is an epidemiologist whose research has focused on tobacco use, substance use, minority health, and health disparities. And his presentation title is Priorities of the Division of Behavioral and Social Research at NIA in the area of disparity research. So please, Dr. Bandiera, share your screen and you can start your presentation.
Hi, thank you. I'll share my screen now. Can you see it there? Can you see the PowerPoint?
Yes, we can.
We see
Oh,
PowerPoint.
okay, let me, okay. So, hi, I'm Frank Bandiera, and today I'll be presenting on the NIA Division of Behavioral and Social Research Priorities and Health Disparities. So let me tell you what I'm going to present on today. First, I'll present about the Division of Behavioral and Social Research. Then I'll present on expert recommendations for our division in health disparities research, followed by resources to facilitate health disparities research, and last, funding announcements from our division on health disparities research. So now I'd like to give you a brief background of myself. I'm a program official at NIA. I'm a social epidemiologist with a portfolio on minority health and health disparities. I administer several minority research centers, and I previously worked at the University of Texas and Food and Drug Administration. But let me tell you about our division. First, we support social, behavioral, and economic research and research training on the processes of aging at the individual and societal level. We also support cross-disciplinary research at multiple levels, from genetics to cross-national comparative research, and at stages from basic through translational. And we support a range of AD, ADRD research in addition to general aging research. We use different mechanisms to support these priorities, such as grants to support research and research resource projects, such as R01s, networks and centers to develop fields, training and career development awards and initiatives to diversify the aging research workforce, such as K awards, and workshops to explore research gaps and opportunities. So now I'm going to get into a couple of papers that our grantees have published, which I thought was of interest. So previous research has established that the association between childhood socioeconomic status and late life cognition. However, the mechanisms that drive this association are not well understood. And adolescent cognitive ability is one potential mediator. So the goal of this study was to examine the multiple pathways through which childhood socioeconomic status affects late life cognition. So Zhang and colleagues used data on 5,880 participants who graduated high school in 1957 and were followed up in the Wisconsin longitudinal study. And they found limited direct relationship between childhood socioeconomic status and late life midlife cognition, and two important pathways: a strong direct relationship between childhood socioeconomic status and adolescent cognitive ability, and between cognitive ability and late life midlife cognition. So, in summary, they found that childhood socioeconomic status on late midlife cognition depended on their effects on adolescent cognitive ability, and childhood socioeconomic status and adolescent cognition both independently affect education, and education impacts cognition in late midlife. So here's another paper. Previous studies have not considered pain as a risk factor for frailty in older Hispanics. So this study by Saudi in 2020 examined pain as a predictor of frailty in older Mexican Americans with 18-year follow-up using a longitudinal study, the Hispanic established population for the epidemiologic study of elderly. And so they found that participants who reported pain with an odds ratio of 1.7 were more likely to become frail at 18-year follow-up. Other factors that were associated with frailty included older age, depression, and disability. So this suggests the need to develop policies to increase culturally appropriate interventions for management of common conditions associated with pain in this population. So now into our portfolio, I should mention that our division is a major funder of health disparities research. In 2000, we did a portfolio analysis of our division in 2019. And we, between 2007 and 2018, we funded 190 projects in health disparities. Most of these projects focus on race, ethnic, and socioeconomic disparities, although others focus on other populations such as sexual and gender minorities. And while the majority of the projects explored environmental or structural variables, the analyses found that more work needs to be done in this area, such as the mechanisms and the sources of exposure. So our findings of this portfolio in terms of publications between 2013 and 2019, we had 1,786 publications in health disparities in our division. And a review of our publications found key themes. The first one is that racial disparities often center on context and resources, that is, factors such as residential segregation, rurality, individual neighborhood, socioeconomic, and access to healthcare. There also persistent racial disparities, mostly Black-white differences. And there are also differences in health systems, including physician bias and greater burden on minority health systems. And immigration and nativity are closely linked to race and health outcomes. And last, racial discrimination leads to poor mental and psychological distress. So every 5 years, our division gets reviewed by our National Advisory Council on Aging, or NACA. Our last review was in 2019, and among 10 recommendations, health disparities was our #1 recommendation. So the recommendations for health disparities encourage looking at differences, but also looking at the mechanisms and sources of disparities. So instead of just saying Blacks more than whites, explaining why Blacks have differences more than whites. And here I have a direct quote from the review emphasizing differences to look at just documenting group differences and looking at the mechanisms. They also wanted exploitation of various data sets to look at the mechanisms. I should mention our division has a lot of secondary longitudinal studies that you could use. So they were mentioning national samples, but also cross-national samples and oversamples. So another recommendation was to look at different samples and data and considering diverse samples. And this is straight from our review. They encourage looking at different levels, such as biological, psychosocial, interpersonal, provider, population based throughout the life course. And they also want exploitation of different data sets. So, and to address our NACA report and our portfolio analysis on health disparities, we commissioned the National Academies Committee on Population to convene an expert meeting on May 18 of 2020 to consider the connections between socioeconomic status and race ethnicity that drive health disparities. So the title of the workshop was a virtual seminar on persistent and large racial ethnic disparities beyond the role of socioeconomic status. And the main theme that emerged from this workshop was structural racism. So our first session was on structural racism by our keynote speaker, Nancy Krieger, pictured below. And structural racism is the public and private policies, institutional practices, norms, and cultural representations that inherently procure opportunity, value, advantage, or disadvantage to individuals and populations according to their race, ethnicity, across both the life course and between generations. So on the right is this figure, her eco-social theory. And if you look at the right of the figure, you can see different levels of racism ranging from global to the individual level. And there are also causal pathways in between, such as economic and social deprivation, responses to discrimination, and land alienation. So one example of how structural racism can be measured is redlining. In the 1930s, a federal agency, the Homeowners Loan Corporation, created residential security maps of major American cities. And examiners graded areas based on criteria related to the condition of housing, transportation, amenities, environmental hazards, the economic employment of residents, and ethnic and racial composition with Blacks. So grades produced color-coded maps with 4 categories for most desirable to hazardous, and the maps were used by loan officers. The ones that were red were hazardous neighborhoods. So these were the ones that were mostly Black neighborhoods or low socioeconomic status. And if you can see in this figure, redlining leads to poor housing and segregation and less access to employment and education and other factors. And this in turn is embodied with stress and results in inequities in preterm birth. So in this table, you could see the HOLC grade and redlining neighborhood varies between the best or green neighborhood to the worst or hazardous or red neighborhood. And if you can see here, there's a gradient increasing between the odds ratio with the red line neighborhoods with an odds ratio of 1.55, it being the worst. And they also adjusted for maternal characteristics in Model 2A and poverty in Model 3A and economic segregation in Model 3B. And these additional covariates explain some of the variance, even though these neighborhoods, these red line neighborhoods were still significant. So here are the themes of the workshop. The first one was on informing policy. It was suggested that social science needs rigorous models of how social inequity is embodied in poor health outcomes in order to inform public policy. The second outcome was that transdisciplinary research is needed to understand race disparities. The third outcome was that future research needs enhanced data collections for variables such as structural racism, exposure, and outcomes. And the last outcome was that there are complex social relationships linked to strengths, vigilance, resilience, and upward mobility that can lead to differential health outcomes. So here's a list of centers that BSR supports. These centers develop key areas of research, making use of networks, conferences, and pilots. A cross-cutting theme of these centers is health disparities. The RICMARs focus on diversifying the aging workforce and decreasing health disparities. The centers on the demography and economics of aging focus on demography and economics, such as geographical differences and family transitions. And the Roy Boyle centers focus on the translation of and integration of basic behavioral and social research findings into interventions to improve the lives of older people and the capacity of institutions to adapt to societal aging. So our main health centers, minority health centers, are the RICMARs. Their goal is to reduce health disparities. They increase the number of researchers focusing on minority or elder health. They enhance diversity in professional workforce by mentoring minority researchers for careers in minority elder health research. They improve recruitment and retention methods to enlist minority elders in research studies. They create culturally sensitive and more precise measures assessing health status of minority elders, and they increase the effectiveness of interventions designed to improve minority elders' health and well-being. So here are some funding opportunity announcements from BSR. One is on immigration, another one on health, on sleep disparities, one on Native American health, and one on health disparities in AD/ADRD, and the last one on structural racism. I should note that BSR accepts applications to health disparities from parent announcements. So we have, beyond these specific calls, you could submit a general application to the parent announcement. And here's a list of our program staff and our specialties in case you're interested in contacting someone. The email is firstname.lastname@nih.gov. So I'm finished. I will take any questions now that anyone has.
Okay, thank you. Thank you, Dr. Bandiera. It was very informative presentation. And first, I would like to ask our panelists, do they have some questions? So if somebody will have question, please ask now, Dr. Bandiera. Okay, so while we're waiting for some other questions, probably I will start with questions. So Dr. Bandiera, could you please briefly summarize the division's priorities for studies on racial and geographic disparities? I mean, do you have some priorities on specific combinations of social and behavioral factors?
Yeah, I mean, we funded disparities for a while, and a big part of our portfolio is on disparities. And we have these funding announcements specifically on disparities. You could apply to the parent announcement. So anything related to disparities, that's in behavioral social research and sociology, economics, epidemiology, psychology, anthropology, anything that's related to behavioral and social research and racial ethnic disparities and aging, we would consider. We have different mechanisms, but you could apply to the parent announcement. And as I mentioned, a priority of our review is not just looking at racial differences, but explaining the reasons for these differences. So why do Blacks have more or less ADRD? What are the reasons? what are the sources, such as racism. So beyond explaining differences, also looking at mechanisms and sources of these differences is a priority to us.
Thank you very much. Thank you, Dr. Bandiera. And I see that raised hand from Dr. Igor Akushevich, our panelist. So please, Dr. Akushevich, you can ask your question now.
Dr. Bandiera, we discussed today at morning session that different time periods can be considered as the source of disparities. So I mean that, for example, time trend, this is something like disparity in time. Do you consider this as a disparity from your point of view?
Yeah, we look at different time trends or cohort differences. So that would be of interest to us, looking at different time periods, different cohorts, intergenerational transmission or differences in disparities. So that would be considered a source of explaining the disparities.
Let me ask another question. We largely discussed today Medicare data. Would you consider Medicare data as one of the main sources of information for grants supported by your division?
Yeah, we fund a lot of existing databases, and a lot of people use Medicare data. So the Medicare data could be used to answer different disparities, populations. So the Medicare data is the commonly used data set that we see.
Mm-hmm. Okay. So if to speak about genetic data, is it also supported by your department or not?
Yeah, we support genetic data. I forgot to mention that we have other divisions. We have the division of neuroscience, we have the division of aging biology, and we also have a clinical division. So depending on your focus, that would go to a different division. Genetics could come to us as long as you have a behavioral and social research focus. So maybe gene environment interactions with behavioral or social factors would be considered by our division. So we do consider genetics, and we do have different program officers that are specialized in that.
Mm-hmm. As I understood from your presentation, healthcare factors are also important for your subdivision. Do you mean pure healthcare factors or interaction with behavior and socioeconomic status?
Yeah, it's in combination with social and behavioral factors, or socioeconomic status would be of interest to us, and also looking at racial differences and reasons for these racial differences, such as cultural factors that could affect different healthcare, immigration, access to care.
Okay, thank you.
Yeah.
Okay, if anybody else have some questions. So we have a question from the Q&A from our audience. And the question is about the studies that establish that hypertension is a major risk factor for dementia in African Americans, and racism is a significant stressor. Are you able, with your data, to establish a mediating effect between discrimination and dementia through hypertension?
Yeah, we have a lot of longitudinal data. We encourage a life course approach. So we do like looking at different age groups over time, and we have a lot of longitudinal data that could answer these type of questions. We have the HRS, we have the handles data, we have the MIDAS data. And I believe all these have these type of variables. And there, I should mention, these are existing databases that you could explore. And we have a lot of rich databases that you can mine to answer these questions.
Okay, thank you, Dr. Bandiera. And probably I can also ask another question. Do you have some studies or some priorities focused on social determinants gradient? It's mean not categorizing social factors or social economic factors, but rather use them as a gradient, like say, or across the US, for example.
Yeah, we consider different levels of measurement. We do follow the NIA Health Disparities framework that was written by Dr. Carl Hill. And we look at different levels of measurement, such as structural, cultural, individual, biological. So it could fit into a spectrum of different levels. We are interested in geographical differences. Life expectancy has changed in the United States. It's improved for some people, and it hasn't improved for some people. And this differs by geographical region. So that would be of interest to us.
Okay, thank you very much for your question. Do we have some other questions? If anybody else want to ask question, please. We have some time.
It's Anatoly Yashin. Could I ask a question?
Yeah, please, Anatoly. Please, you're very welcome.
Okay. Thank you. It was very interesting presentation. And my question is that it's related to the fact that the important component, the important source of disparity is the exposure to different kinds of stressful environmental conditions. But it's also well known that such kind of exposure is not only influence the health and survival outcomes. It influences through mediators which are, let's say, developed, which are produced by genetic expressions. So gene-environment interaction plays a crucial role in difference among people, not only just environmental conditions. So I mean, the source of disparity includes genetic component and interaction of genes with the environment. Do you think it's important topic for research in the grant for NIH?
Yes, that's important. You know, we are interested in gene environment interactions such as stress or at different structural, but not just structural, but you know, individual level too. So things like allostatic load,
Yes.
Perceived stress, and how that interacts with different genetics. We are interested in that, and we do take applications in that.
Okay, great, thanks.
Okay, do we have more questions? Okay, I think we've done for now. So thank you very much again, Dr. Bandiera, for a very informative presentation, and we will definitely work on submitting new studies and addressing the priorities that you described in your presentation. Thank you very much for your presentation. Thank you.
Okay, thank you.
And
You're
I
welcome.
think we can move. Yeah, thank you.